Hello everybody. Today's topic is total parental nutrition. Total parental nutrition is the medication used in the management and the treatment of malnourishment. It is the nutrition class of drugs. Parental nutrition is the intravenous administration of nutrition outside the gastrointestinal tract. Total parental nutrition is when IV administered nutrition is the only source of nutrition the patient is receiving. Total parental nutrition is indicated when there is inadequate gastrointestinal function and contraindication to the enteral nutrition. Enteral diet intake is preferred over parenteral as it is inexpensive and associated with the fewer complications such as infection and the blood clot but requires functional immune system. Now we'll see indications. Chronic intestinal obstruction as occurring to the intestinal cancer. Then the bowel pseudo obstruction with the food intolerance. TPN can also be used to rest the bowel in case of GI fistulas with high flow. When an infant's gastrointestinal system is immature or has congenital gastrointestinal malformation. When there is a postoperative bowel anastomotic leak. When the patient is unable to maintain nutritional status due to severe diarrhea or vomiting, small bowel obstruction, hypercatabolic status due to sepsis, polytrauma, and major fracture, and anticipated period of meal by mouth status greater than 7 days, as in patients with inflammatory bowel disease exacerbations as well as critically ill patients. Now we'll see the mechanism of action. Total parental nutrition is the mixture of separate components which contain the lipid emulsions, dextrose, amino acid, vitamins, electrolytes, minerals, trace element. So the total parental nutrition composition should be adjusted to fulfill individual patient's need. The main three macronutrients are lipid emulsion, proteins, and dextrose. So the lipid emulsions, it provides calories and the prevents fatty acid deficiency. Essential fatty acid deficiency may develop within the 3 weeks of fat-free TPN. 25% to 30% of total calories are in the form of lipids. A soluble protein, a solution that contains essential and non-essential amino acid except arginine and glutamine. Healthy adult requirements are 0.8 to 1 gram of protein per kg per day. This change is based on the condition of the patient. A critically ill patient requires 1.5 gram per kg per day, and the patients with the chronic renal failure are given 0.6 to 0.8 gram per kg per day. Patient with the acute hepatic encephalopathy need temporary protein restriction to 0.8 gram per kg per day, and patient on hemodialysis need 1.2 to 1.3 gram per kg per day. Now, carbohydrate provided through the dextrose monohydrate in the variety of concentration, most commonly 40%, 50%, and 70%. Glucose utilization maximum rate is 5 to 7 mg per kg per minute. Excess carbohydrate supplementation can result in hyperglycemia and hypertriglyceridemia. So, electrolytes, trace elements, and vitamins are micronutrients. Trace elements and vitamins dosing can be according to the recommended daily requirement. Electrolyte recommendations per liter of parenteral nutrition. Now the sodium is 100 to 150 milliequivalent, magnesium 8 to 24, calcium 10 to 20, potassium 50 to 100, phosphorus 15 to 30. So the total nutrition is the admixture, that is a 3-in-1 solution of 3 macronutrients, that is dextrose, amino acid, and lipid emulsions. A 3-in-1 solution and intravenous lipid emulsion mixed with electrolytes, trace elements, vitamins, and water. Parenteral solution with only dextrose and amino acid with the separate intravenous lipid emulsion infusion. The 2-in-1 solution has been previously used. The research has shown the TNA, that is total nutritional admixture, to be standard of care for adult TPN. Currently used TPN amino acid mixture continues to be incomplete with only 19 amino acids. The non-essential amino acid glutamine has been used as the complement to TPN to complete the amino acid content of TPN. That is, glutamine 8% to 10% in parenteral nutrition is complementary. A critical care patient have decreased glutamine level on admission, which continues to decline until the third hospital ICU stay. Both high, that is more than 700 nmol per ml, and low, that is less than 400 nmol per ml, shows the statistical correlation with the mortality than those with the normal range between 400 to 700 nmol per ml. Now, how to administer total parenteral nutrition? Total parenteral nutrition administration is through central venous catheter. A central venous catheter is the access device that terminates into the superior vena cava or right atrium and used to administer nutrition, medication, and chemotherapy. The insertion of central venous catheter can be through one of the large three central veins, that is femoral vein, subclavian vein, and internal jugular. Central venous catheter are used when the administering TPN for several months or years. Establishing this access could be through peripheral inserted central line, that is PICC line, central venous catheter, or implanted port. So the PICC line insertion can be through basilic vein, cephalic vein, brachial vein, median cubital vein of the arm. So the basilic vein is the preferable due to its larger size and the superficial location. The catheter course through the basilic vein to axillary vein and to the subclavian vein to settle in the superior vena cava. PICC line could be used when TPN is administered for several weeks to months. Now the next access is implanted port. It is a device that is implanted under the skin in the chest, that is, which is attached with attached catheter inserted into superior vena cava. So the implanted ports are used when administering TPN for years. Total parenteral nutrition is not administered through peripheral intravenous catheter because it has a very high osmolarity. So the peripheral parenteral nutrition osmolarity needs to be less than 900 mmosmol per mmosmol. The lower concentration necessitates the higher volume feeding and high fat content is necessary. High osmolarity irritates the peripheral vein, hence the TPN is given through central venous access. Peripheral parenteral nutrition is used to provide additional nutrition to patient with functional gut and enteral feeding. Now we'll see what are the adverse effects. The main adverse effect can be due to metabolic abnormalities, infection risk, and the venous access associated. So the venous access, now we'll see the venous access associated adverse effect. It is associated with insertion of central line catheter, that is a pneumothorax, air embolism, bleeding venous thrombosis, and vascular injury. Catheter site infection, bloodstream infection, known as sepsis, local skin infection at insertion or exit site. Now the metabolic abnormalities, refeeding syndrome. Refeeding syndrome is the chronic alcoholic patient and patient who have nil by mouth status for more than 7 to 10 days. That is a hyperglycemia. Sudden discontinuation can lead to hypoglycemia. Hypoglycemia is corrected with 50% dextrose. Then the serum electrolyte abnormalities, wernicke's encephalopathy, and parenteral associated cholestasis. Now, how to monitor? So intake and output chart should be maintained, like 12 hours chart should be there. Then urine sugar estimate we should maintain every 8 hourly. Then we should keep the daily record of sodium electrolytes like sodium, potassium, bicarb, calcium, and chloride. Serum creatinine and the blood urea levels should be we should monitor daily. Serum protein levels twice daily. Liver function test twice daily. Then we'll see what are the contraindication. Infant with less than 8 centimeter of small bowel, irreversibly decerebrate patients, patient with the critical cardiovascular instability or the metabolic instabilities, such instabilities require correction before administering intravenous nutrition when gastrointestinal feeding is possible. And when nutritional status is good and only short-term TPN is needed. The lack of therapeutic goal, as TPN should not be used to prolong life when death is unacceptable. Unacceptable. The American Society for Parental and Enteral Nutrition guidelines include patients who recently received TPN should be monitored until stable. They require more frequent monitoring if metabolic abnormalities are detected or if the patient has risk of refeeding syndrome. Now, the refeeding syndrome can occur in severely malnourished and cachectic individuals when feeding is reintroduced and can lead to severe electrolyte abnormalities. Refeeding syndrome can correlate with hypophosphatemia, respiratory distress, rhabdomyolysis, and acute kidney injury. So, the prevention of refeeding syndrome in critical care and achievable with the slower uh, so the prevention of the refeeding syndrome is critical and achievable with a slower initial infusion of TPN than would be expected. So, unstable and the critically ill patient should be monitored until stable. Stable hospital patient with no formulation changes for 1 week should be monitored every 2 to 7 days. Stable hospital, home, and long-term care setting patient with no formulation change for 1 week should be monitored every 1 to 4 weeks if clinically stable. Now, the toxicity. Generally, toxicity of TPN is related to the individual toxicity of its component. Increased caloric requirement amount due to TPN, glucose, and lipid excess can lead to hepatic toxicity. This risk can be decreased by using decreased glucose content and greater lipid content. Glucose infusion rate greater than 5 mg per kg per minute can result in fatty liver. This is because increased glucose in the blood induces the hepatic lipogenesis and increased glucose level trigger the increased insulin level leading to more lipogenesis. This effect is preventable by decreased dextrose dosage to under 5 gram per kg per day, less than 5 mg per kg per minute, and cyclic parenteral nutrition for 8 hours as it decreases hyperinsulin, substituting 30% dextrose energy with the lipids. Parental nutrition supplementation rather than total parental nutrition is harmful to pediatric patients in pediatric intensive care unit. Parental nutrition supplementation should be withheld in the first week in PICU, independent of age and nutritional status. This is because amino acid in parenteral nutrition suppresses the autophagy process needed for cellular damage removal. Excess amino acid shuttle to urea production. Increased urea level can pose harm to kidney and liver. Long-term usage of TPN ranging from weeks to months can be associated with rare complication of manganese toxicity. Manganese exposure via TPN is characterized by the high bioavailability due to bypassing GI tract regulatory mechanism. This high concentration of manganese over time lead to its deposition into the liver, brain, and bone. However, the brain is most likely to be affected as manganese will deposit and affects the globus pallidus and striatum of the basal ganglia. Manganese preferentially affect the dopaminergic neuron in the basal ganglia, resulting in extrapyramidal symptoms that present in similar way to the Parkinson disease. Idiopathic Parkinson disease can be differentiated based on the location of neuron affected, that is in substantia nigra. Now, this is the trial which is published in NEGM in 2013. That is a randomized trial of the glutamine and antioxidant into the critically ill patient. So, the background of this trial is critically ill patient have considerable oxidative stress. Now, the glutamine and the antioxidant supplementation may offer therapeutic benefit through the current data are conflicting. So they have included 1,223 critically ill patients, and supplements were started within 24 hours after admission to ICU and were provided both intravenously and enterally. So the primary outcome was 28-day mortality. Because of the interim analysis plan, a p-value of less than 0.044 at final analysis was considered to indicate statistically significant. Okay, and the result is increased mortality at 28 days among patients who received glutamine as compared to those who did not receive glutamine. So the final conclusion was the early provision of the glutamine or antioxidant did not improve clinical outcomes, and the glutamine was associated with increased mortality among critically ill patients with multi-organ failure. Thank you.